Thanks very much, Karen, and thanks to SHOP for inviting us to talk today about transfusion-transmitted infections. So I'm here with my colleagues, Tali Yavic, who's going to start first. Tali is one of the scientists in the joint NHS Blood and Transplant UK Health Security Agency epidemiology team. Very long title. And my other colleague, Katie Davison, who is principal scientist in the team, will also be talking about the wider work of the unit. And then after that, hopefully, you might have some questions for us. So without further ado, I will hand over to Tali. Thanks, Tali.
Thank you very much, Sue. So as Sue mentioned, I'm going to be talking about TTI surveillance. And if you didn't catch it, TTI are transfusion-transmitted infections. Since 1996, our team has been collaborating with SHOT for the surveillance scheme. This is a passive surveillance scheme, so we rely on hospitals to report to the blood services. And once we receive a report from the hospitals, we initiate an investigation into a possible infection in a transfusion recipient. Data is collected, but we also may use this data to initiate a look-back investigation, and this would be in a repeat donor who's got a newly identified infection, and we look at their previous donations. So all data that's collected is looked at and investigated. This includes details from the hospital about the infection, details of the transfusion and the blood components, any details about the infection and possible risks, all details of mortality or morbidity, and any results from bacterial culture or molecular testing are used in these investigations. Investigations will conclude with a classification of a transmission or not, and that transmission could be confirmed or probable, amongst other final conclusions. We also reconcile our data with the SHOT office because they get reports from other sources. So we reconcile all that data and compile it into the annual TTI chapter in the annual report. Next slide, please. So a TTI is defined as if after an investigation, a recipient has been shown to have evidence of an infection following transfusion, where there was no evidence of the infection before transfusion and no evidence of an alternative source of the infection, and either at least one component received by the infected recipient was donated by a donor who had evidence of the same infection, or at least one component received by the infected recipient was shown to have that agent of infection. This definition can be further classified as being confirmed or probable if a transmission has occurred. A confirmed TTI is as above, but there is evidence that the virus or bacteria is indistinguishable on molecular typing between the patient and the donor or the donation. A probable TTI is as the definition above, but where molecular typing cannot be carried out to confirm this. Next slide, please. So in our data for 2023, which is reported in the chapter, this is a summary of the data. There were 140 reports that were investigated in 2023. The majority of them were for suspected bacterial incidents, but none of them were confirmed to be probable or confirmed TTIs. The majority were post-transfusion reactions where there was no evidence of bacteria following investigation. Of the 26 suspected viral incidents, there was one confirmed hepatitis A TTI, 2 probable TTIs, a hepatitis B and a hepatitis E infection, and the remainder were not TTIs or undetermined, and at the time of reporting there was one pending. Investigation was still undergoing. In addition to this, there was a suspected parasitic incident, and this was confirmed to be a malaria transmission. Next slide, please. So if you put the results for 2023 in context with the time that we've been running the surveillance scheme, which is 1996, you can see on the top image of the confirmed TTIs, the numbers have been coming down quite steadily. And over the past 10 years, we average about 1 to 2 confirmed TTIs per year. Initially, there was a high number of bacterial TTIs, but that has decreased quite drastically. The last confirmed bacterial TTI was in 2015. I'll explain some strategies we've incorporated to get that down. And if you look at the probable TTI image on the bottom right, you can see there's been a handful again, 1 to 2 a year of probable TTIs, although these have only been captured since 2012. So the definition of a probable TTI was only really used since 2012. If If you can move to the next slide, please. Thank you very much. Just to discuss some of the case studies that we reported on in our annual report. The first was a confirmed hepatitis A transmission. This was a regular donor who developed symptoms of acute hepatitis within 2 weeks of them donating blood, and they were subsequently diagnosed with a hepatitis A infection. They were found to have hepatitis A IgM antibodies, and RNA was detected. This donor was asymptomatic at the time of diagnosis of their infection, but they subsequently developed significant transaminitis. The recipient was identified and they were followed up for hepatitis A testing. The donor and recipient virus sequences were identical. This was a rare 1b subgenotype, and this was used to confirm that the hepatitis A virus infection was acquired via the red blood cell transfusion. The implicated donor was deferred for 6 months, but will be eligible to donate should they wish to do so. Hepatitis A virus infections are very rare in the UK, and blood donations are not routinely screened for hepatitis A. Although now testing for hepatitis A and human parvovirus B19 are being conducted to facilitate collection of plasma for fractionation. Next slide, please. On to our next case study, which was a confirmed malaria transmission. A recipient had multiple red cell transfusions and they had no overseas travel or other likely risks, but they were diagnosed with malaria. So the donors were identified and archive samples from these donations were tested and they were shown to be negative for malaria antibodies. Despite this negative initial screening, samples from 6 other donors were also subjected to further testing based on their clinical history. And one of those donors was identified with Plasmodium malaria DNA in their blood sample and identified as the likely source of this transmission. Ongoing work is still continuing to type the malaria that has been found in the donor and the recipient. The donor has been removed from the donor panel and appropriate medical review has been arranged in the recipient, and look-back investigations have been initiated into previous donations from the donor. The patient has received treatment and is clearing their infection. Up until now, discretionary malaria antibody testing based on their travel history has been effected. The last reported transmission in the UK was in 2003. But policies and procedures are being reviewed to see if any further mitigations are required. Next slide is the case study of a probable hepatitis B transmission. This was an older person had been diagnosed with acute hepatitis B infection during their hospital admission. Blood transfusion was considered as the most likely source of their infection, as it had multiple transfusions 6 months prior to their diagnosis of hepatitis B. 33 donor exposures were investigated, including looking at the archive samples from previous donations, and 2 donors were found to test positive for anti-Hep B core antibodies. These donations were collected before the full implementation of anti-Hep B core screening, which was rolled out in 2022. One donor had evidence of a past hepatitis B infection, together with high levels of anti-HBs antibodies, and another donor was found with a hepatitis B infection, but with low levels of anti-HBs antibodies. Hepatitis B virus DNA was not found in either of these donors, but it was probable that the recipient acquired the hepatitis B infection via a blood transfusion from the second donor. Transmission couldn't be confirmed, but circumstantial evidence that the donor originated from the region where the recombinant genotype DE is prevalent, which is the same genotype that was identified in the patient, thus further supporting transmission. The 2 anti-Hep B core donors have been removed from the donor panel. The SHOP chapter ends with a few key shot messages from our team and from these data. And as usual, confirmed or probable TTIs are rare, but any suspected TTIs should be reported so that they can be investigated. There is still a small but a potential risk of testing not detecting an infection in a donor, which may enter the blood supply, but it's important to remember that not all infections are tested for. Blood samples are stored for at least 3 years, but these can be retested during this time if a TTI is suspected. The UK Blood Services monitor rates of infection in donors to sustain a safe supply of blood components. And this data, together with shot data, is used to inform policy and change it when necessary. just to finish off my section, this is a resource we put together to show the risk reduction strategies in the UK for bacteria as well as for viruses, parasites, and prions, and how they link to the number of TTI incidents that we have identified over the years of surveillance. If you look at the bacterial image on the top, you can see that since the final strategy introduced by 2011, which was bacterial screening of platelets, the number of TTI incidents has reduced. There were other strategies that have been introduced before then, including ChloroPrep arm treatment for all donors, as well as diverting the first 30 mils of blood, which has resulted in a reduction in bacterial TTIs over the 30 years of surveillance. Similarly, for viruses, parasites, and prions, you can see the number of TTIs has reduced since the different risk reduction strategies, and those include more sensitive testing and additional screening, including the most recent introduction of anti-Hep B core screening, which was introduced in 2022. And just to say that these TTIs reported on this image represent incidents of TTIs. So a handful of them will correspond to more than one recipient being affected, but for the purpose of this image, they're just the incidents of the TTIs. So if you move on to the next slide, please, and I'll hand over to Katie.
Thank you. Thank you very much, Tally. So I'm going to talk to you. My video is on. Can you see me? Can you thumbs up somebody?
Yes.
Yes, okay. Sorry about that. So hi, yeah, so I'm going to talk to you about the close monitoring of the blood donations. So that's very much part of the work that we do to help keep the recipients safe. So the slide that we're showing here is actually, just the one picture back, please, Karen, is the front cover of our annual review. So this year it's called Safe Supplies 2023 Close Monitoring of Blood Donations. So we're going to give you the link to find that report at the end, but that's where a lot of these data come from. Next slide, please. So in this slide, you can see that surveillance is at the top of the blood safety pyramid. So the aim is to monitor the impact of each of the different safety strategies that we have in place to keep blood safe. So it starts with donor selection, where you
Katie, you got mute. You're on mute.
I've muted again.
Okay, sorry. Shall I start from the top of the pyramid?
Yes, please.
Yeah,
Thank you.
sorry about that. Don't quite know what happened. Okay, so this is the blood safety pyramid, and surveillance is at the top. So the aim of the surveillance is to monitor the impact of each of the different stages in the pyramid. So safety starts with donor selection. Blood safety starts with donor selection, where people at increased risk are asked not to come and donate blood. Then we have a number of processes and quality control measures to help keep blood safe. And we also have a number of tests. So testing began in the early 1940s, initially with syphilis, and then with hepatitis and HIV testing following from the 70s, 80s and 90s. So over the years, since these were first introduced, these particular tests have become more sensitive. And then we've added a number of additional tests, so for HTLV and HEV, and the latest was an additional test for hepatitis B in 2020. So patient blood management is there to make sure blood is used appropriately, and TTI and look back is the haemovigilance system that Tally's already described. Next slide, please. So how do we do our blood donor surveillance? Well, there's a number of data collection schemes that we use. So, and there's a number of different sources rather. So it starts off, we collect the donor demographic information. So when donors first register, so that will tell us how old people are, their gender and their ethnicity. We look at the number of donations by new and repeat. We collect the screening test results for the assays that I just discussed, including whether infections that go on to be confirmed or not. And then a really important part of the surveillance scheme is collecting the information on clinical follow-up. So we've done that since surveillance began back in 1996, but it's been a relatively unique system in the world where not all donors who are found positive are interviewed. It's becoming increasingly more popular around the world, but it's really helpful because it helps us to understand about how people acquired their infection. Next slide, please. So the purposes of our blood donor surveillance scheme is really to be able to monitor trends in infections in our donors. We use those data to estimate the residual risk, which is the chance the testing doesn't detect an infection that could enter the blood supply. These data have been frequently used to inform policy reviews, so not just for donor selection, but also for addition of new tests that have been included. And we support public health programmes by providing data to national surveillance schemes at UKHSA. So we know from our surveillance schemes that donor selection works. We see very few infections in our donors. And because we see very few recent infections, that helps to keep a very low residual risk. And we know that what we understand from this scheme is that donors are very compliant. So part of our surveillance scheme is we try to focus particularly on our recent infections, because that's what tells us more about the safety of the supply. We keep a close eye on the risk factors so that we know whether people are compliant or not with the donor deferral criteria. And we also ask people why they were not compliant. And that helps us to evaluate the impact of the criteria. So one step back, just two big policy reviews that we contributed data to recently were the review of the GBMSM deferral and also the removal of the people whose partners had sex in sub-Saharan Africa. So we were able to provide data that enabled the blood services to remove those two deferrals safely and help to increase inclusivity and diversity in the donor population. Next slide, please. So quick look at our surveillance data. So these are our UK trends of positive donations from our first-time donors and our repeat donors. So on the left, you can see that the scale is much higher than in our repeat donors. So we see rates much higher in our first-time donors, and that's because these are mostly past prevalent infections that are removed from the supply. The exception, I suppose, to this is at the end. So it's been a downward trend over many years, but just in recent years, we've seen an increase in recent syphilis in both our first-time donors and our repeat. And that's reflective a lot as part of what's going on in the general population at the moment, where we've seen a number of ongoing outbreaks of syphilis. Syphilis and repeat donors, we've seen some increase as we've changed the assay that we've used. So in recent years, we've picked up past syphilis infections that were not detected by the previous assay. Next slide, please. So I mentioned to you about residual risk. So that's the chance that testing does not detect a window period infection. And that's really important because it indicates what the likelihood is that testing could have missed a donation that could have entered the blood supply. So in the UK, we have a very low residual risk, and it's been less than 1 in 1 million for over 10 years. So just to give you an example of how that interprets, in 2021, 2023, we'd estimate that we'd miss about 1 hepatitis B infection every year. It would be over 50 years before we could miss a hepatitis C, and about 10 years since we would miss an HIV. And that's a lot to do with two factors. One, we see a very low incidence of these infections in our blood donors, and two, we use highly sensitive NAT testing, which is a very small window period. Next slide, please. So the Joint Epi team also undertake horizon scanning. So that enables us to keep a close eye on emerging infections around the world that might impact on the safety of the UK blood supply. So we produce a monthly emerging report, and that's a horizon scanning list of outbreaks, emerging and re-emerging infections which could potentially affect the supply. We use a range of national and international sources. And if there's something urgent that needs to be escalated, we've got the system to do that so that it can be reviewed without delay. We're a joint team with the UK Health Security Agency, and we've got good links with public health surveillance to help to support us in this. The resources we use are reviewed annually, and stakeholders are regularly asked for feedback. So we have a clear process established for risk assessment. So these reports are taken up to JPAC and SACT, where they decide whether action is required. And on the map, you can see some of the actions from 2023. So they were centred around observations for the spread of dengue and West Nile in Europe. So the spread of West Nile and dengue in Europe has brought increased complexity to testing and deferral decisions. So we've had to extend seasonal West Nile testing and the deferrals to more areas of France and Spain. And West Nile testing was the highest level since 2000. Sorry, West Nile testing in 2023 was the highest level since 2012. Next slide, please. So here, this is a comparison that we did, and it's produced in our annual report this year for people to have a look. We wanted to put together what blood donation has shown, blood donation safety can tell us, sorry, then and now. So we started in 1996 when our surveillance scheme was just set up. And at this point in time, HIV was much higher in the general population. There was about a third of all cases of HIV were undiagnosed. We had a permanent deferral in place for GBMSM, and testing was limited to serology for Hep B, Hep C, HIV, and syphilis. So we saw about 455 donations positive, or a rate of about 16 per 100,000. And although we saw low numbers of recent infections, we were detecting recent HIV, Hep C, and hepatitis B. So the window periods of the assays that we used then were 15 days for HIV, 60 days for hepatitis C, and up to 80 days for hepatitis B. So those window period estimates, those number of recent infections impacted on the residual risk. So we saw a higher level, so over 1 in 1 million for hepatitis B back in 1996. And as a result of this, we did see some TTIs, low numbers back in 1996, but we had 6 detections altogether. So go forward to 2023, and we see a different picture. So by now we'd had nearly 30 years of surveillance data. At this time, HIV is very different in the population to what it was back in 1996. Nearly 94% of cases are diagnosed and on treatment for HIV, and there's a very low number of undetected HIV, which is important for the safety of the blood supply, because more people are aware of their infection if they are infected. As I mentioned before, we've now removed the GBMSM deferral, and we've got an individualised risk assessment in 2021, because we were able to identify GBMSM at low risk of infection. So testing, as I mentioned before, has been extended. So it's not just serology, but we've also got highly sensitive NAT tests in place as well, and bacterial screening. So the number of infections that we detect has decreased to just over 100 positive donations, or 6.6 per 100,000, and that includes hepatitis B, by the way. We have a low number of incident infections each year, and that gives and much lower window periods for the tests that we use, and that gives rise to the lower the lower residual risk of less than 1 in 1 million. And as Tali mentioned to you, we had 2 confirmed transmissions in 2023. None of those were Hep B, Hep C, or HIV. Next slide, please. So just want to acknowledge all of the blood donors and recipients for supporting the surveillance programmes, SHOT colleagues who support the work of the chapter, the blood services across which the surveillance schemes collect their data, hospitals who report into SHOT, and our UKHSA colleagues. Thank you. I think it's back to Sue.
Thanks very much. Karen, are you taking over?
Hi, yes. We've got a few questions to ask, and please feel free to put your questions and answers questions in the Q&A box at the bottom of your screen. I can hand over to Vicky now for the first question.
Hi, thank you. That was a really informative webinar. Oh. Sorry, my phone. Thank you for that really informative webinar. It was great. First question that I'd like to pose to the TTI team is, what's the reporting route for any patient with a suspected TTI across the UK, and what information would reporters need to provide?
I think I'm probably going to take that. Thanks, Vicky. So I'll kind of focus on England because that's where I'm based on, know a bit more about the process. So it really depends whether this is a suspected bacterial TTI or whether it's a viral or potential parasitical TTI. So for bacterial TTIs, generally these are going to be spotted very close to the time that they're happening, and it is something where we really need people to act quite quickly. So generally in England, there would be a discussion with the on-call NHSPT consultant, really to discuss through the case. Because with bacterial TTIs, it may well be that we'll be requesting for packs to come back for microbiological analysis. And also in the case of apheresis platelets, there might also be other packs that have been issued or potentially transfused. So we want to try and get those recalled as soon as possible. When it comes to viruses, things are slightly different because often these will have been reported sometime after the transfusion in many cases. And in very occasional cases, it will actually be the recipient who comes to us directly. That is quite rare, and we don't really want to encourage that. So usually we would have reports coming in from the clinical team who've looked after the patient. Generally, they come in directly to us, although we do encourage people to talk with their local infectious diseases team before they report, just to exclude other potential sources. In England, for both of these, there is a form on the hospitals and science website. So there's a specific form for viruses and things like malaria. Information we require really is background about what's actually happened, some information about the recipient, micro results if available, but we really would like the micro results if possible before we would investigate, and also a list of transfusions, ideally either as a screenshot or with some sort of identifier so that we know it's come directly off your system. So as I said, there is a form there, and also on the hospitals and science website, there's information about how to send those to us, and we have a generic email address. Across the rest of the UK, generally similar approach, with the first point really being your local blood service clinical team for advice and support in terms of investigation. Is there anything I've missed? That's about it, really. Hopefully everybody will be able to find the forms, but I'm sure we can provide a link for England at least to where the forms are for investigation.
Thank you so much. So we have a question coming through the Q&A. Please put your questions. So the question is, who is responsible to notify the patient when there is a recall for TTI, for example, HIV?
So, sorry, this is to notify. So we would notify the patient at the end of the investigation. So certainly in the UK, we generally communicate with the clinical team who are looking after that patient. And what we would normally do, we would have kind of kept them notified of what's going on, that the clinical team. And then once we have an outcome, we would talk with the clinical team, send a final letter, also usually with a copy for the patient. And also we would say that we're very happy to talk with the patient and all their family about what's happened, explain where something might have gone wrong. Thankfully, these days, HIV transmissions are very rare. It's probably worth noting at this point, many people on this call will be aware of the infected blood inquiry and the tragedy of what happened in the 1980s and the early 1990s. And still we are getting people coming forward trying to find their transfusion records from that time. So we are at the moment having a number of people asking how they go about getting records. So generally they're needing to go to the hospital first to initiate that. But there are still some people coming through at the moment. Hope that helped.
Oh, that's wonderful. Thank you. So, in terms of I suppose you don't have a typical notification, but for the bacterial investigations and for the viral investigations, what kind of time frame would that normally take from start to finish, or is it dependent on the case?
For bacteria investigations, they tend to move quite quickly, really. If there's packs to investigate, we're kind of limited by how quickly or not the bacteria grow, to be honest. And then there might be some other investigations. For bacteria, actually, we usually kind of have a sort of small investigation team. There may be some donor work that we need to do as well. For viral investigations, they can take a very long time. So we are talking months rather than weeks. In a recent case, which we've just closed, I think it's probably started early in the year, probably about February time, but we did have to try and chase one of our donors around the country because they'd retired from donation and they'd also moved several times. So there's quite a few moving parts when it comes to a viral investigation. But we do try and keep people updated as to what's going on. But certainly bacterial investigations tend to be relatively quick.
So we have a couple of questions on the chat. So the next one is, are patients who have a TTI eligible for compensation?
Need to take this one? I don't know where my colleagues are. I'm sitting here not answering any questions, but anyway, I think compensation is probably down to me. So this is very much probably an English answer to this. It's a similar issue across the UK, but law slightly different across the UK. So if we have a known transmission, as I said, we'll often talk to the patient, the family, and we would usually say to them at that point, you are eligible to make a clinical claim. Currently, many of these claims will be under the Consumer Protection Act because of a faulty good. Following the IBI, there are some new compensation schemes starting, or some adjusted compensation schemes. So previously, people wouldn't routinely get compensation for hepatitis B transmission, and the new scheme is very much compensation, whereas the other sorts of claims we tend to call clinical claims, because I think in legal language it's not compensation. I don't fully understand the difference, but so we would generally advise people that, you know, they're very within their rights, and obviously at that point as well we'll apologize for what's happened, and we will in many of these cases we will get to the point where we're involved in some of those discussions, and usually that does get to a point where a clinical claim will be awarded.
Thank you, Sue. I think we've touched on this one, but just to reiterate, when there's a confirmed transfusion-transmitted infection, who should report it, the blood service or the clinician responsible for the transfusion?
Usually it'll be the clinician reporting to the blood service. Is that in terms of sort of shock reportable, or?
It's just reading, it's from the chat here. So,
oh, okay.
Yeah.
So I suppose in terms of if it's proven, then we will, obviously we're doing our shock reporting thing, but also that the hospital should also be reporting. And generally in our closing letter, we will say to people to finalise your shock reporting. I mean, if it's not TTI, then obviously that's a whole different matter. But also, I think, don't know, Tally might want to mention what we do just to make sure that we don't miss anything through the year.
Yeah, that was the reconciliation that we do with SHOT. So things get cases get reported into SHOT. They go on to Spine, I believe, or Sabre, and then we do a reconciliation where we check if we have details of them and if they're on our database. So we reconcile that data. I think that's what you mean, Sue. Unless there was something I forgot. So everything should be covered.
Thank you, Sue and Tally. So we have another question on the chat. So how does UK compare with other countries international with regards to TTI?
I'm going to let Katie take this one.
take this one. So I think we would agree that we've got one of the safest blood supplies in the world. And we know this from our blood donor surveillance data because we see very low infections. We know it from the residual risk because we've got a very low chance that testing would miss an infection, and of course from our haemovigilance scheme that we've got in place. We do see some differences internationally, and that can often be to do with the local epidemiology. So some countries will have a higher rate of hepatitis C, for example, than we do in the UK. So you would expect to see more hepatitis C in blood donors. Similarly, some countries don't have such good access to testing, so you in the public health system, so you might find more undetected infections being picked up in their general population, like syphilis or HIV. So the short answer is, I think we've got one of the safest systems in safest supplies in the world, and the other part of that answer is, and we have the surveillance in place, data to back that up.
Thank you. That's, oh, sorry, did we go to join in to whoever getting noise cost over? That's fine. Thank you. Thank you. It's nice, reassuring information there. So the next question to come from the Q&A box is, how in depth would you advise a conversation about the risk of transfusion-transmitted infection when consenting for transfusion? And are there any resources to support these conversations other than the standard NHS BT leaflet, which the attendee posted the question said is great. So they do like that leaflet.
I can kick off, Vicky. So I think it's a great question, and also the leaflet has been developed following the SAPTO consent guidance as well. And I think this is a combined effort of the UK and Ireland Blood Transfusion Network. So there is a consent leaflet, as you know, for the patients as well as for the healthcare professionals. The other thing that we wanted to also highlight is actually an app that we have been working on with all key stakeholders, and this is called the My Transfusion app. This is primarily actually directed to share transfusion relevant information with patients. This has been co-created with transfusion recipients and is undergoing testing at present, but that also would be actually an additional resource that can actually build on the available consent leaflets in these conversations in the shared decision making. And I think the important aspect is the transparency. So all the data about the probable confirmed infections are on the SHOT website and the QR code that you have in the background. Equally, the safe supplies report as well that you have is actually telling about the testing and the results that we currently have. So I think it is important to actually keep up to date. These are reported and updated annually. So I think that provides all the necessary information. But I think I'll pass on to Sue as well. Is there any additional information with the consent process that they can use?
Yes, thanks, Shruti. I think your final point about keeping up to date is kind of quite important, particularly over the last couple of years where we have had new tests coming into place. And also in England and actually already in Scotland, we will be bringing in more new tests next year when we have hepatitis A and B19 testing. Currently, we are already testing, but not actually in real time in England at the moment. So I think that that's important, particularly as I think, I'm not sure if it was Tally or Katie mentioned, we did introduce an additional test for hepatitis B, so this anticore test in 2002. And that was very much driven by the transmissions we were seeing going back to SABTO, which is the Department of Health Expert Committee, and them then establishing a working group to look at this and note that with this additional test, then that was hopefully, and I think it is working by what we're seeing, would greatly reduce the risk of occult hepatitis B. So whereas 2 or 3 years ago, that might have been something that we might want to sort of discuss. Now that risk has greatly reduced. Now we have an additional test in place.
Thank you very much. So we have one last question on the chat. So from the confirmed and probable infections reported, how many have been in pediatric patients?
I couldn't tell you off the top of my head. I'm not sure if Tally can. It is quite rare for us actually to have a transmission in a child. The recent malaria transmission was, I think as Tally noted, in a young child, but generally, if we do get a TTI investigation where a viral one at least, where it is involving a child, it's usually kind of quite surprising because it's very rare that we see them. I mean, maybe that probably reflects transfusions that are given. I don't know, Talia, are you able to? We might have to come back to you on that one, I think.
Yeah, I have to check the database.
Fab, thank you. And just to encourage anybody, because we've got 20 minutes of the session left, so please feel free to put your questions in the Q&A box. This is a Meet the Experts session, so it's more conversational, a bit of background. So please do, we do want to receive your questions in the webinar. One that's open in the chat box at the moment is asking about, are there any other tests being considered or any other mitigating measures going to be introduced to improve microbiological safety?
Quite a big question. So I guess there's, as Katie was talking about, we have ongoing surveillance for a number of infections, particularly insect-borne infections, which are kind of an ongoing concern at the moment, particularly as sort of insects, I was going to say march their way across Europe, probably fly their way across Europe. So that's something we keep a close eye on. I think many of these issues will get considered at SAPTO. Some of them will be considered at JPAC as well. And often it's a bit of a cost-benefit balance, really. Certainly when it comes to things like travel deferrals versus a test. There really is that tipping point whereby we're deferring too many people, which is kind of what happened really with West Nile virus back in 2012. That we get to the point where, yes, we really do need to introduce the test. Mentioned Hep A B19, which was very much introduced because our plasma for medicine wasn't really a specific risk reduction measure for whole blood. SAPTO have got some reviews going on at the moment. Hepatitis E is another virus that gets routinely reviewed by SAPTO in terms of, are we doing appropriate testing? Because that is something that we thought the number of new infections each year, that sort of like the incidence might increase or decrease because it's foodborne, so it's kind of quite different to some of these other viral infections. So apart from Hep A B19, there isn't anything else in the UK about to come on board that I'm aware of. I don't think I've forgotten anything, but there are always quite a few things being kept under consideration.
Thank you. There's another question. How do we collaborate with international colleagues for horizon scanning for emergent infections?
I'm going to pass this one to Katie, I think.
So in terms of collaborations with reports coming in, so we work very closely with the UK HSA, who've got their own links with international colleagues. So and those will come through regular alerts through public health systems. But in terms of collaborating with blood safety colleagues, so reporting out, so either telling other colleagues what's happening or them telling us in terms of directly affecting blood donors, I think that goes through the EBA, Emerging Infectious Disease System. Is that right, Sue? Did JPAC collaborate at an international level as well?
Well, CPA Monitor Group is
CPA
that has
Monitor
a
Group.
member, usually the members in JPAC.
Okay, so that's where that fits together.
And there's your group that you're a member of.
Oh yes, and then I sit on a subgroup of ISBT. So there's the ISBT, International Society of Blood Transfusion. They have a transfusion-transmitted disease subgroup, and a subgroup of that is a surveillance and risk assessment group. So I sit on that group. So we talk a lot about arboviruses and how countries are monitoring the infections, managing, and that sort of thing.
Thank you for that nice in-depth answer. It's quite interesting to see how everybody's working together. One more question here in the chat is asking about the recall process. So when there's a recall from an HSBT is initiated, but the product's been transfused, what should the clinical investigator be looking for before the formal recall report is received to confirm or rule out contamination? And is there any guidance on how to investigate recalls to help ensure that nothing is missed?
Right. I think probably the majority of recalls are going to be related to bacterial screening, and I'm suspecting that's probably what the question is about. So the whole of the UK carries out bacterial screening, and certainly in England we issue units as negative to date, but that means that bacterial screening process is going on in the background after these units have been issued, usually around probably what in reality is about day 4 post the donation. So at any point the machine may go ping, which results in a recall. But what we know is those pathogenic organisms are likely to have grown in that time that the sample's been on the machine before the units get issued. That's basically why we chose that time. And those recalls after that time are most likely going to be due to something called Cutibacteria. And to date, there really isn't any evidence that that is likely to cause any impact in a patient. It tends to be one of those organisms that's sort of deeper in the skin, that it doesn't matter how much we cleanse people's arms, we're really not going to be able to get rid of it. And it is an organism that grows much better in an anaerobic environment. So the chances are, even though we're detecting it on culture, it probably hasn't actually survived in platelet packs. So if there is a significant organism or something that looks like when final IDs are done, it's likely to be significant, we will be in touch with hospitals to advise. But for the most part, as I said, these are going to be, I was going to call them innocent bacteria, no bacteria innocent, but those less pathogenic bacteria. And really the clinical team should be looking out for those usual signs and symptoms. And if they have got concerns, then to talk with their ID team. In terms of the other recalls that might happen, I guess are for post-donation information. So Tally mentioned the hepatitis A case where we investigated as quick as we could once we got some post-donation information. So in those cases as well, we are generally informed and will be in touch with the hospital as soon as we can if we think this is something significant. And also our colleagues in the clinical support team are also involved in managing these out of hours. There's very few recalls, I think, at the moment that might be related to real viral transmissions. Occasionally there will be recalls, but we would certainly be in touch if these are real, and we would also be advising on the particular virus, and probably in these cases, particularly in the hepatitis A case, our virologists got involved quite quickly to talk to the local ID team and think about ways we could try and mitigate the risk of transmission. So that's kind of how we do it in an HSBT, and I think this is kind of a similar setup across the UK.
Thank you, Sue. So there's a question: how can we properly handle suspected cases of TTIs in the clinical setting?
Ooh, well, that's yeah, I'm not quite sure. I mean, I think depending on how the patient's presenting, I think certainly on the viral side, exception being when people sort of develop jaundice. Many of these cases are picked up due to additional testing, sometimes because a patient has moved from one hospital to another, or because of the time lag involved. It may well be that the patient has felt well and gone to their GP. So I think viruses are quite tricky. The malaria case was identified by the clinical team, and that because there was malaria in a child with no obvious travel history, in that case, the UK Health Security Agency got involved, so the health protection team was stood up, and there was a number of experts involved in that case to support the local team. So there was experts from the London School for Hygiene and Tropical Medicine. And I think for where there is suspected bacterial transmission, then I think it's important to get the ID team involved, because if that is a real transmission, then obviously there is going to need to be antibiotics administered, and they might need to be changed depending on what the outcome is from blood cultures. So I think hopefully that helps. I don't know if Shruti wants to add anything from a sort of somebody who's practiced hospital medicine point of view, rather than a job in public health person here.
No, thank you, Sue. And I think it's been quite some time since I've also handled this. But I think the key thing from what we note is actually keeping everybody informed and up to date. I think the communication is actually really important. Sometimes we also see that there is a delay in suspecting that, but also involve your local hospital transfusion teams. And again, liaising with the blood service consultants and the microbiology consultants is really key for this. But all along also actually, with that openness and the candor with the with everybody involved. So I think that is the main thing that I would actually then say. I think that may segue into one of the questions that has been put in, is also how long do these investigations take? So
well, how long is a piece of string? So I think for bacterial investigations, they will generally, we're talking a few weeks, but they're usually much quicker. But I think for the viral investigations, they can take, I think, as I mentioned before, they can take several months. But also what we sometimes find, if this is a proven case, then the particular implicated donor at that point, and I think Tally mentioned this earlier, we will then start a look back on any other previous donations they might have made if they've got some sort of chronic infection. So often something that's an identified TTI will then end up as a look back. And then unfortunately, sometimes we might find another recipient who's been affected. I mean, that is rare, but it does happen. And it was really an issue with occult hepatitis B because of the nature of occult B being a chronic infection with fluctuating levels of hepatitis B DNA.
I've just seen a question. I've got a colleague with a hand up, but I don't know whether that's an artifact on the call or not. If not, I'll just go ahead and ask the last question that we've got here in the chat that might be the most on people's brains a little bit. But have there been any reports of transfusion-transmitted COVID?
I'm not aware of any in the literature, Tally. We haven't had any to investigate, have we?
No.
And I don't think, as far as I'm aware, I don't think there is any literature that suggests that's the case. I think early on there was a lot of debate, but I'm not aware of any evidence.
Thank you. So we have time for more one or two questions. So I have one that is not on the shot. Do you keep patients and blood donors involved, informed throughout the investigations?
So with patients, generally, we don't usually talk with patients directly, apart from at the very end, but we will try and keep the clinical team updated, particularly if it's a very long investigation. If we're inviting donors to give additional samples or swabs in the case of bacteria, we will explain to them what's going on, but generally we will say that you are one of several people involved in this investigation. So we're very keen that, there's no sort of blame felt at all. It's rare that we would say to a donor, this patient has an infection, it was because of you. Well, we will never say that, but certainly the donors, we'll inform them what's going on, but it's very light touch and a very sort of, you're part of a whole load of people being investigated here. Yeah, so that's kind of how we approach it.
Thank you, Sue. I think there's one more question. Vicky, would you like to take that question? I think it's in the chat.
Oh, fab, thank you. Sorry, I've not seen that one there. Sorry, I didn't, we were closing now. So just quite a lengthy question, but I think the gist of the question at the bottom is there any difference in the incubation time for a virus when it's transmitted through blood transfusion or any specific conditions that might make it it was not transmitted in a different way? So if it was, was there any difference in the incubation period through transfusion or through transmission in a different mode?
I think the main thing that we see is really, it depends very much on the patient, and because many of the patients who are going to be having transfusions are immunocompromised, I think that's the thing that's going to make the big difference, and particularly when it comes to clearing viruses. And also it can mean that we get all sorts of unusual things happening in the patient, that if they're immunocompetent, their results wouldn't look quite the same. So I think obviously it's a very efficient way to transmit a virus by giving them quite a lot of blood. But I think in terms of incubation periods, it's very much about the patient that's going to drive that.
Thank you very much for all those great questions. It's exactly what we want on these Meet the Expert webinars. If you think of any burning questions afterwards, which is quite often the case after these events, please do send them through to us at the SHOT email address, which is shot@nhsbt.nhs.uk, and we'll try our best to answer them. In the last few minutes now, we're just going to run a live poll, and we'd really appreciate you taking a few minutes to complete it. It does help us guide our future resources and webinars. So the poll is there on your screens for you to submit the answers. Once you've done that, there should be a submit button at the bottom right where you can submit that to us. So while you're answering those questions, I'd just like to remind you that this session is being recorded and it will be uploaded to our website as soon as possible. And we do appreciate your feedback and comments and suggestions about haemovigilance and the work that SHOT does. So please do feel to get in touch with us. Email is always the preferred route. You can visit our website at www.shotuk.org for lots of the resources we've mentioned and reports, and they're all free and you can use them in your educational activities. And for those of you who don't know, we also have them available on our app. And if you haven't got that, you can search SHOT UK in the App Store. So please keep an eye out on our website for future Meet the Expert webinars. There's a list of those. A huge thank you to our speakers today and for all of you for joining us, and also some of the hidden members of the SHOT team who've been responsible for the exceptional running of the webinar using Zoom there in the background. So we hope to see you all again soon, and thank you very much for joining us today.
Thank you.